everyone, and thank you for joining today's webinar this afternoon, POLST in the Hospice Setting. This is the final webinar in our webinar series using the National POLST Paradigm to honor patient treatment wishes across the care continuum. All the other preceding webinars were recorded, and they can be found at polst.org/toolkit, and we will also be posting this webinar later today as well. We encourage you to ask questions during today's presentation. You can find a chat box at the bottom of your screen in the bottom left, and we'll address all your questions at the end of the presentation today. I'd now like to briefly introduce our presenters, Kandyce Powell and Jane Dorhmann. Kandyce has 30 years professional experience working with end-of-life issues, and she has been the executive director of the Maine Hospice Council and Center for End-of-Life Care in Augusta, Maine since 1992. Jane is the director of Honoring Your Wishes, a community-wide advanced care planning initiative in Iowa City, and she has served as a programs director since 2010. Jane has also facilitated implementation of IPOST in her respective county since 2013, and she serves on the statewide IPOST task force. I'd now like to welcome our presenters, Jane and Kandyce.
Thank you. Thank you for this opportunity to be with all of you today, and we look forward to sharing our insights and perspectives on what we've learned through POLST implementation. Kandyce?
Good afternoon, everyone. It's a pleasure to be with you. This is Kandyce, and I would just like to add a couple things that we've done here ever so briefly. The Maine Hospice Council was designated as the administrative home for POLST back in 2008 because we're a neutral entity, and so we've been the administrative home ever since then, and it's been a privilege and a pleasure, and it intersects with many of our other programs. So I think I'll be starting. Jane, if it's okay with you, I'll just take it from here, and I'll
Certainly.
go right to the first slide. One of the things that is always amazing to me about the work that we do, and I'm sure all of you do, is the intersections between all aspects of healthcare. And I think when we can recognize those overlaps and intersections, it all makes so much more sense, and it really results in a seamless, hopefully, delivery system. The first slide that we're going to be talking about is goals of care discussions in hospice. And hospice is so familiar with many of the basic precepts of POLST. And one of them, of course, is the goals of care conversation, is sitting and listening to people and realizing and recognizing that we will never understand values and preferences unless we take the time to spend with folks. I often think that our lack of investment in time is the enemy of community and well-being in our society. And we know that POLST is more than a forum. It's an approach to end-of-life planning based on conversations. And Jane and I can't stress that enough. And I know all the other presenters have stressed that as well. And it's about including the family. And family means, of course, a network of close friends and biological family and other healthcare professionals. And the POLST paradigm is designed to ensure that seriously ill or frail patients can choose the treatments they want or do not want, and that their wishes will be elicited, documented, and honored. And we can't stress that enough either, and I know, again, that you've heard about this from many of the other presenters, but it's important to keep reiterating. And it's intended for people who have serious illness or frailty, for whom healthcare professionals would not be surprised if they died within a year. And again, that's another question, that surprise question, that hospice often asks when it's evaluating whether someone is appropriate for hospice. So when discussing goals of care, we need to make sure we describe the comprehensive interdisciplinary services that hospice has to offer. And there are so many aspects of this, again, that we need to make sure that we recognize and value between hospice and POLST. POLST just helps hospice patients actually clarify their goals of care many times. The integration of the POLST paradigm and hospice. POLST provides more personalized care and treatment options than traditional CPR and DNR orders. CPR is really just about CPR. It's not about additional treatments that might enhance comfort and quality of life. And that's the beauty of POLST because it offers the conversations that get to those additional treatments. There's a wonderful article that's cited here by Hickman and Toll and Hams and others. And it's one of the, I find it's one of the best articles about the value of POLST in hospice programs. And one of the things about hospice too and POLST is that POLST conversations underscore the value of the various team members that engage in the conversations. It could be a social worker, it could be a nurse, it could be a physician. And all of those perspectives really add to the understanding and the dimension of helping folks decide whether certain treatment options are appropriate for them. In this article, it really does suggest that most hospice patients, when they have POLST forms, and in the Hickman article again, it looked at West Virginia, it looked at Oregon, and it looked at another state, Wisconsin, and it decided that the patients that the hospice programs that used POLST were very pleased with the results of that, in that it helped them certainly understand more in detail about the preference options and the treatment options regarding treatment goals. And there was a lot more clarity for them. I'd like to, we know that stories are very important for all of us, and I'd like to just capture a story. Jane's going to tell you a story too. This was several years ago when I was working in an institution here in the state of Maine. There was a young woman who was diagnosed with ALS, and this certainly would have been a perfect opportunity if POLST forms were available then. She had chosen every available means of technology to stay alive. And she used to use a word board when her muscle tone was such that she could no longer speak. And so some of us were comfortable with a word board and some staff were not. And it's interesting because when we communicate by other means than just verbalization, it challenges people. We've all seen that happen. So her primary physician came into the hospital one day and said to me that he would like me to go in and talk to this young woman about dying. That it's ridiculous. She needs to be honest and upfront with the fact that she's dying. And I, with all due respect, I listened carefully, and I just simply said to him, you know, I have had many a conversation with her about the fact that she's not going to reverse her illness, and that she has indicated her wishes and her values. She chose to go on a respirator because she wanted to complete her degree in anthropology before she died. And so she has some very definite goals. Those things were all outlined in the chart. But a POLST form, I think, would have been a clearer means of recognizing in one form the depth of the conversations, the breadth of her thoughtfulness when it came to decision-making for herself. And I have often thought of that story. There were a lot of communication issues, of course, that certainly needed to be improved. But I think the POLST form in that case could have been a perfect vehicle for more clarity in allowing staff to quickly recognize her wishes and the reason for her wishes. So why don't I just turn this over to Jane so she can tell you another very compelling story.
Thank you, Kandyce. Well, I'd like to share an example of how POLST can be a very helpful communication tool for families or caregivers as well. Let's take the example of a caregiver, we will call her Elena, who flew across the country to be with her mother, Maria. Her sister, Flora, had been caring for her mom, their mother, with the support of hospice care. Upon Elena's arrival, Flora told Elena that she needed a break, as we know our caregivers do, and that Elena would be in charge the following day. Flora took the time to review her mother's medications with her sister, as well as the POLST form, and told her sister that their mother's wish was to stay at home and not return to the hospital. If Elena had questions about caring for their mother, she was instructed to call hospice, not 911. The POLST form provided clarity for Elena and assisted in ensuring that her mother received the type of care and treatment that she wanted. Both of the daughters found the POLST form to be very helpful in communicating with one another about how to best care for their mother. I'd like to continue with giving some examples of another family and how to bring up POLST with individuals and families, and how to provide education about the use of POLST across different systems of care. So I would recommend that if your hospice provides informational visits, that you introduce the POLST paradigm at that time. The individual and family may already have a POLST in their home. They may or may not. And I would encourage you to provide educational materials for the individual, the potential patient, their family members, and any caregivers who would be assisting in the care. Specific instructions about what to do with the form in case of a medical emergency, or if the person is transferred from one care setting to another, should be reviewed at the beginning of care and or at informational visits and then followed up upon. So let's give an example of Joseph, age 80, and his spouse, Julia, who is the primary caregiver. Upon admission, Julia's first question was, how can I go to my granddaughter's wedding in May? I'm providing care for my spouse, and I'm afraid that he may not be able to travel, but I'd really like to go to this wedding. The social worker was able to describe the hospice caregiver benefit, respite benefit, and services that could be provided at the local hospice unit in the hospital. She explained that Joseph's POLST form would go with him to help ensure that his health care preferences would be honored. Joseph was comfortable with that plan and thought that it would work. So spring came, and it was time for the wedding. Joseph was not able to travel, and so he was admitted to the hospice unit at the local hospital for caregiver respite. At that time, the hospice team and Joseph reviewed the POLST form with hospital staff. day, the hospital staff agreed to follow his wishes if there were a medical crisis or if his heart and breathing stopped. The hospital staff placed Joseph's POLST medical orders into their electronic health records or electronic medical records as actionable medical orders to be acted upon. Julia went to the wedding. She was able to see their granddaughter Mary, and hospice volunteers and Joseph watched the wedding via FaceTime on the hospice unit. Upon Julia's return, Joseph's POLST form was reviewed with the hospital and hospice staff. His goals of care remained the same, and he was discharged to his home with his brightly colored POLST form. Joseph had his POLST form placed at the foot of his bed so that everyone would know his wishes regarding his care and treatment. Picture of the bride and groom. Kandyce?
Yes, it's really important. One of the things I've recognized over the years is the value of POLST in regard to grief and bereavement. And there's just beginning to be some research on that to kind of make a correlation between the two. But long time, I'm sure most of us have knowledge of the value of conversations, thoughtful conversations about goals of care early on, and the enduring nature of those conversations, and the implications on the grieving process. Even though the dynamics of dying, we all know, can be extremely sad for all of us. When we know we've listened to somebody's wishes, that we've honored somebody's preferences to the best of our ability, and I'm talking healthcare professionals, I'm talking family, I'm talking everyone in the network of support, there's an element that in my 30 years of work in the hospice field, it's just so apparent to me that it has a direct correlation to our grief process. So I hope there continues to be more research on that, and I think it will benefit all of us and add a quality indicator for us to follow as many of us have developed POLST implementation in our own organizations and institutions. So I just wanted you folks to, Jane and I talked about that a lot, and we both wanted you to just think about that and consider that in your own quality improvement programs. Jane, anything you want to say about that in addition?
I think you've covered it, Kandyce. Thank you.
All right. I'd like to segue now into training interdisciplinary healthcare team members, but I'd also just like to talk a little bit more about the value of an interdisciplinary team itself. And there's also a lot of research out there that shows when an interdisciplinary approach to care planning is implemented and is part of the standard of care, it actually results in more effective care plans earlier on. And if there's continual assessment and reassessment, it all makes a great deal of difference. You know, the issues of end-of-life care and serious illness and chronic advanced illness are so complex, and to many of us it only makes good common sense that more than one person should be involved in the decision-making about someone's care. And certainly the focus needs to be on the person, him or herself, and their family as the center of that care planning. So Jane and I can't stress enough the importance of an interdisciplinary team approach. And of course, that's one thing that hospice from the get-go has embodied. And again, so many intersections between the values that POLST has and the core tenets of POLST and the core tenets and values of hospice. And there are many models out there now that are looking at some concurrent models, Medicare Choices model and Aetna, as we had said earlier on. So when we segue into training interdisciplinary healthcare team members about POLST, we need to do initial training, of course, but before we do that, we need to build an infrastructure for our organizations and institutions and make sure we do our due diligence and our homework. We need to put guidelines in place for everyone. And then we need to, follow that. And I'm sure all you folks on the phone do this every day of your lives in your own institutions and organizations. And it can't be stressed enough. I call it, we can't just do one and done. We have to make sure that every team member, every interdisciplinary team member knows what their roles are and what their responsibilities are. And we need to provide the support for them. Lots of times we just train people and then we let them go do what they do, and we trust them and they are professional people and work under a license. But they're human beings and they need support. And with POLST, having challenging conversations about difficult issues, we all know that's sad on a good day. So, but it can be thoughtful, it can be thorough, but we have to make sure we support the team members that are having these conversations, just as we need to make sure we support the patients and the family members. An initial conversation may start upon admission, but we have to play it by ear, don't we? Just like we do when we go in and meet a hospice patient and family for the first time. We need to assess where they're at, and we don't want to barrage them with a lot of things depending on where they are emotionally. So we might need a shorter visit first, maybe not, and then come back. And we need to make a good, thoughtful decision ourselves as to when to introduce something like POLST. And the patient should be our guide. Just like in any conversation, whether it's a professional conversation or a personal conversation, if somebody knows we're listening to them, then they are more apt to share with us, and they are more apt to keep sharing with us. If they don't think we are listening to them, or if we're too busy, or if our productivity issues are getting in the way of our presence with them, then we're defeating our purpose, and we're not doing these patients and families a service. So I feel strongly about that just personally, but I also do professionally, as I'm sure all of you do too. So we need to do initial training, but then we need to keep doing reassessment and support, both for the caregivers, both for the team members, for everybody really. Goals of care, of course, should be reviewed at every visit, and at that time, discussions about POLST may be had. You might introduce it once, and you might not receive too warm a welcome, just like maybe introducing other resources. Don't be daunted. If you find a window of opportunity when you can segue into it again, if that presents itself, then, it's our emotional intelligence really that helps us understand when the time is right to have these discussions and introduce additional resources. And again, really assess someone's understanding, what they know about the situation and the circumstances, what they know about the resources that you suggested to them. Do they understand the benefits and burdens of some of the choices that they have been offered? So many things to remember, I think, but common sense really for us all. So now Jane's going to talk about the community and the importance of community engagement.
Thank you, Kandyce. Yes, we were fortunate when POLST became state law in Iowa that locally we already had a community-wide advanced care planning initiative, Honoring Your Wishes, that began under the leadership of Iowa City Hospice in 2010, when we felt as a hospice that we wanted to provide leadership in improving health care in our region. And so a community coalition was founded. We began to implement advanced care planning strategies with initial conversations and providing leadership in that role. So when POLST became law, we were thrilled and then could integrate that. It was a natural integration into our existing structure. So I would argue that hospices have an opportunity and perhaps a responsibility to provide education about POLST, the benefits of POLST, best practices, and ways to successfully implement this really important paradigm into the care that we provide, and in improving the care of all of the people in our community, all of the people that we care about. So would really encourage you to think about successful strategies for POLST implementation in your respective community or healthcare system. And so I'm going to share a couple of strategies that have worked well for us over the past several years. When I think of POLST, I think of it as a puzzle with many pieces. I'm a social worker. This model works really well for me because I believe that it is systems work at its core, and it can create a beautiful picture, and it can work wonderfully in assisting people in receiving the type of care and treatment that they want at the right time when all of the systems work together. When I think of POLST, I often think of the principles of self-determination and informed consent, and it really helps people more clearly understand what their choices are in a succinct way. And it also really helps healthcare providers work together across systems because they can read the person's wishes at that time. It's also really wonderful if a person cannot communicate, that their choices are clearly expressed in a medical order. And it can help reduce family conflict because if they're thinking about making different choices, going back to what did mom say that she wanted? What did she remember the conversation we had on this day? She can't communicate right now, but she clearly stated what her preferences were. So continuing to bring that back and forth as a part of conversations and what to do now and what to do looking forward can be very helpful. However, as you may know or can imagine, one missing link in this puzzle can be detrimental. Can be detrimental to that individual who has carefully chosen what she or he wants for their health care. And we don't want anyone to be overtreated or undertreated. We really want people to get the right kind of care at the right time according to their wishes. So I go back to hospice and our responsibility. And part of our responsibility is to care to the best of our ability for people who would like to have hospice. They make that choice. We know nationally that various studies have shown that the majority of people would prefer to die at home or in their home-like environment. But conversations about hospice as an option for care may not have taken place. I'm guessing many of you have heard people say, oh, if I had only known about the comprehensive services that hospice provides, I would have called sooner. So we want to help create bridges and access to care for those who choose hospice for the type of care that they receive, either individually or collectively as a family. When we were preparing for this work and the chapter that we've written in the Toolkit, I came across a study that took place in Oregon. It was a retrospective study that looked at 18,285 POLST that had been registered in their system in 2010 and 2011. And from that study, they showed that over half of the people who had a POLST died within 2 months. So my question is, as a part of that POLST discussion, were they offered hospice as a choice? How many of those people selected that as a choice and received the type of care that they wanted at the right time? So again, when we think about our opportunities to reach out to the community and provide education about POLST, Kandyce and I came up with a list of all of the places with whom we've interacted and provided education and support about POLST. And it's a very rich opportunity to connect with these folks, other professionals, and other leaders to create awareness about the POLST paradigm. Kandyce, I think you'd like to share a specific example.
Yeah, thanks, Jane. Actually, I thought of a couple, so I'll make them both short. But one of the things that I do every year is I have a partnership with the VA Medical Center here in the state. We have one VA Medical Center, and they ask me every year to spend time during their stand down, for those of you who are familiar with the stand down, to spend all day, either a day or two, sitting and listening to veterans who just happen to be homeless, and listening to them about what their preferences and values and wishes are for their advance directives. And it's one of the most profound days that I spend. It's just poignantly moving, and I encourage you all to do the same thing. And it's amazing. We think we know who the people are that live on the streets, and we don't unless we take the time to get to know them. So that is one thing I do, and I often speak to them about POLST as a choice and an addendum, if you will, to advance directives. And I explain it to them, and they're so receptive. So again, I hope you all consider doing something similar. The other story that I just wanted to capture ever so briefly was my work at the Maine State Prison. I started a hospice program there 17 years ago, and I've had many an occasion to recommend that the prison, the care provider that is the subcontractor for health care there, adopt the POLST form as again a complement to advance directives. And most recently today, I offered my services to do a goals of care conversation with a gentleman that they had transferred to the hospital against his will, but they said he did not want to sign a DNR, and so they transferred him to the hospital. The hospice team, we had worked with this gentleman and thought he was going to be able to die in place. So I extended my services again today and asked if I could assist them with a goals of care conversation. And I'm teaching there tomorrow, and I offered to bring a POLST form in with me to share with the healthcare provider in hopes that they might one day soon decide to adopt the form and avoid some of the unfortunate dynamics that happen in the infirmary with some of the patients unnecessarily. So I don't know if any of you do work in your own prisons or correctional facilities, but there is an opportunity for POLST dissemination and education everywhere that does health care. So thanks, Jane.
Certainly. So I'd like to give a couple of other examples. We want to, of course, remember our children who are maybe appropriate for POLST and the incredible benefits that it gives to them and their caregivers, their family. And many children are still going to school who may have a POLST form. In our state, the University of Iowa Hospitals and Clinics palliative care team did an amazing job developing tools and resources to reach out to schools to let them know what POLST is and how to use it appropriately if the child who's attending their specific school would have a medical crisis. So again, lots of different ways that we can reach out to different organizations to make sure that people's healthcare preferences are honored. I would also say that it's incredibly important to meet with local emergency responders or to have a structure in place for that. And depending on where you live, if you're in a city or in a rural area, that will differ in terms of the structure. So in some parts of our country, we know that there are many, many volunteer emergency responders. And so we will need to make sure that each and every one of them also knows about POLST and what that means, and that it is a medical order that they can follow and they are protected in that process. So when you're thinking about developing a community coalition to provide education about POLST or to make POLST successful in your area, some of the things that I have found very helpful to think about or consider are the questions that are posted. We, of course, want to find people who are strong advocates for person-centered care. That is critical. But in addition, we also want to look for people who can influence change and provide leadership in their respective organization to successfully implement the POLST paradigm. So I encourage you to thoughtfully consider that as you develop or strengthen your current structure. This is a picture of our advisory board with whom I work, who I'm accountable to. And it is a whole host of people representing a variety of backgrounds and disciplines. So I have representatives from our local hospitals, from the city of Iowa City, from care centers. I have lawyers representing the legal community, faith community representatives. Of course, Iowa City Hospice is at the table. Nonprofits, and then businesses. So all of us together who are assisting with planning, any kind of planning actually, and support to people have representation. And so that has worked very well. And together we have set community-wide goals and measurements to determine our success. Just want to share with you a couple of other examples. We did a quality improvement project in 2 of our local nursing homes to provide support and assist with implementation of best practices of POLST in their respective settings, and that went very well. We actually worked with a social worker and a nurse at 2 care centers, have that interdisciplinary approach and successful implementation. Also worked very closely with our Director of Ambulance Services in our county. And, through all this work, we've continued to learn and grow. And one of the things that we recognize is the importance of including POLST information in staff orientation materials. So as you know, in any setting, there's turnover. So how do we help make sure that people are aware of the POLST paradigm right away and what their responsibilities are? And another piece to that is regular follow-up. Kandyce mentioned earlier about the importance of supporting the interdisciplinary team with POLST implementation. I would encourage you to think about that in terms of your regular staff meetings or interdisciplinary meetings. Have you addressed POLST and its success or its challenges, and how can you help work out the kinks to make sure that it's as successful of a process as possible?
So what we'd like to do now, in the interest of time, because you folks have very kindly allowed an hour to join us today, we'd like to take some of your questions, but we'd like to just address a few frequently asked questions, and we'll do it briefly so we can get right to your questions. And I see a few coming in. So I'll go right to the ones that are on the slides in front of you. And the first one is, what are the hospice policies regarding CPR and DNR? Well, again, a lot of people don't understand what CPR and DNR actually are, so a thoughtful conversation about those is certainly a priority. But hospice programs differ in their policies, and what's important is that the patients and families, or anybody interested in the particular organization, ask right up front what those policies are. And have the hospice program clearly state their policies regarding CPR and DNR, and maybe even post them on their website and other social media, or wherever they do their posting. So that's really important. Just ask the question, encourage patients and families to ask the question. But when they ask the questions we need to ask them is and are about what do they understand about CPR and DNR, because CPR is just about CPR. It's not about what other treatment options for comfort care that the person might want. So make sure that the questions are asked, but that there's clarity in the responses that folks get and their understanding of these issues. When should the POLST conversation begin with hospice patients? And there again, it depends really on the emotional intelligence of the person who's sitting down and having a conversation with the patient and family. If it's the social worker, if it's the nurse, whomever it is, and it might not be right at the get-go. It could be if it's appropriate, but like we do everything, we need to just judge it on what the person is telling us and what we're hearing, both by what is said and what is not said. So we do a lot of work with emotional intelligence here, and I do a lot of training on it, and it's just so critical in healthcare. And it's no less critical when it comes to POLST conversations or any conversation for that matter. So there's no set time. Patients and families need to thoroughly understand their options for treatment and care, including POLST. Another question often asked is, the hospice admission process takes so long, should a POLST form be offered at admission? And again, I think I covered that a little bit. If you have other questions about that, be certainly pleased to address them. Certainly one would say yes if there's time to do it, and if the time is right to do it. If you get a sense that it's an appropriate window of time, then certainly offer it as a list of several options when you do an admission. So I think I'll leave it at that for now, and if you have other questions, you can send them to us and we'll address them in the time that we have left. But I think Jane has a few questions that she'd like to add before we go to all of your questions.
Thank you, Kandyce. Yes, just a few more that, whoops, they're not coming up when I press this. Let's see. We just have a couple of more questions about that we often get asked. One is when a POLST form should be reviewed. It should certainly be reviewed upon admission. It should also be reviewed, of course, whenever the individual or family requests that. When goals of care are reviewed, so specifically interdisciplinary team meetings is a wonderful time to do that. And then upon transfer to another level of care or setting, because goals of care may change, and so we want to make sure that the POLST form represents the current wishes of the individual. Revocation is another time to review the POLST form before a person may be discharged. It's also incredibly important that staff document all of the POLST conversations, and if the form needs to be changed, that they document the current wishes of the individual. If your form needs to be changed or voided, please refer to your organization or state protocols for voiding the form. There should be a process in place. We also often get asked which member of the hospice team should guide POLST conversations. Well, of course, you want to be person-centered, and so it depends on the circumstances of the individual and family. However, in terms of staff, you want it to be the individuals that feel comfortable with POLST conversations. They should have received training and should be knowledgeable about the POLST paradigm. So it could be a nurse, a social worker, the spiritual counselor, medical director, attending physician, or nurse practitioner, depending on their availability and what makes the most sense. And the completion of the POLST form should be done in accordance with state regulations regarding the scope of practice for each licensed discipline. So conversations take place, and then we need to make sure that the form is legal and valid. It's important to recognize that licensed providers are responsible for signing the medical order, specifically the attending physician or the hospice medical director or the nurse practitioner. Policies ensuring that the POLST form becomes a valid medical order may vary depending on the location of the hospice patient. So for example, perhaps a nursing home may have certain protocols that might be different than a private home where you're serving or an assisted living. So that process needs to be recognized. And then also it's really important to think about verbal orders and how that relates to the completion of the POLST form. So we want people to follow whatever policies are in place regarding an RN taking a verbal order from a licensed provider. And with the exception of a few states, faxed or photocopies of the form are considered valid. So you want to make sure you have an understanding of that in your respective state, and then also the protocols that you choose to implement in your respective organization. Thanks.
We would just like to, there are a list of references for you folks. I know a couple people have asked for the full citation. We would just like to end our section of this and then take questions, but before we do, we want to make sure we thank the Pew Charitable Trust for the opportunity to participate in writing a chapter on hospice and POLST for the Toolkit. So we are most grateful for that privilege. Thank you very much. And I think now take questions from all of you patient folks out there. Anna?
Sounds good. Thank you so much for your presentation today. We do have a few questions to get through, and if anybody thinks of questions after the webinar is over and wants to reach out to us, you can email at toolkit@polst.org, and I'll connect you with the presenters. So yeah, the first question that came in, can a minor have a POLST form, and can a minor designate a surrogate?
So this is Jane. My understanding across that in all states except Colorado, a POLST form a child may have a POLST form if they meet the medical guidelines for a POLST. So, for example, it's the surprise question is our national best practice model. Would we be surprised that child would die in the next year? If so, then yes, it's appropriate to have a POLST conversation and to complete a POLST form. Can a child choose a surrogate? It's the legal guardian or the legal the person who's the legal representative, so a parent, for example, or a legal guardian for that child. So we want to include children in the conversation as is appropriate developmentally, and I think that's just really important in terms of the care that is provided. But they cannot legally select someone to be their spokesperson if they're under the age of 18. Kandyce, do you have anything to add to that?
No, I think you did a very nice job covering that, Jane.
Yeah. Great, thank you, Jane. The next question, what determinants are you using to determine success?
There are so many that one could choose. I think quality improvement programs are wonderful if we don't overextend ourselves and if we just focus in on a few things and do them well and then evaluate our program and then choose others. So I think it depends, number one, on if we're doing an evaluating a program organizationally, administratively, or clinically. So I think we need to ask that question first. And certainly we've talked a lot about interdisciplinary team, and I think there are many aspects of that we could pull out to evaluate as to determine the success of the team approach to care, if that's what the questioner was asking. But I think bereavement is another one that I mentioned when I did one of the slides. I would like us to be able to follow families. Maybe this is in the future, but I would love to see us really take a look at the value of POLST when it comes to the grieving process, factoring in some of the social determinants that families are living with and individuals are living with. Certainly the setting itself, when you're measuring success, is fraught with social determinants. I mean, my work in the prison, the men are dealing with trauma that's been impacted by many social determinants in their lives. So I think, number one, we just need to be willing to and allow the time for conversations around this issue. It's a great question, and it's one of my favorite questions to dive into and dig deeply into. So I would be glad to, if the questioner wanted to contact me personally, I'd be glad to share more in detail about that. But it's an opportunity for us, I think, all of us in our programs and our organizations and institutions. And I know one of the determinants that I have personally been very passionate about is the connection between individuals and families having POLST forms and the number of people who are able to die at home. And there's a direct correlation between that. So I think that is a wonderful indicator to tease out and put into your quality improvement program.
And I'll just give two very brief examples. So when you're starting POLST implementation, are the forms filled out correctly? Are they signed correctly? Are they what the patient wanted? Another example is, are their wishes honored? So did they receive the type of care and treatment that they wanted? retrospective audit is helpful in determining that.
Great, thank you for your responses. The next question we have, can a non-terminal person have a POLST form?
Well, that certainly is controversial, but what we state when we lay out the basic tenets for hospice and POLST, or POLST itself, is that it's someone with serious illness or advanced frailty. So I have heard of a lot of institutions and organizations that require POLST forms on everybody, no matter what their status is. So Jane, you might have some input into that. I know Iowa does things a little bit different than we do here in Maine, so you might want to weigh in on that.
So we always want to make POLST a choice. It should never be required. But yes, a non-terminal person can have a POLST, I would add, because they may be frail elders. So would we be surprised if a 100-year-old person or a 95-year-old person or a 90-year-old person, for that matter, died in the next year? You know, that's higher than the average age. You know, we want to look at their health conditions, their contacts, but a person in their 90s, I wouldn't in general be surprised if they died. So it's an opportunity for a more in-depth POLST discussion. So I do think we want to include our frail elders in that discussion, and that's a whole other question. You know, how do we look at the term frail and how is that measured? But there are various tools out there to determine if someone is frail, and so if the clinician believes that they wouldn't be surprised if they died in 1 year or less, that's the guideline. So the answer is yes.
Great. Thank you for your response, and I have one final question for you that came in. Can the designated surrogate change the care preferences defined in the patient's POLST form?
Well, Jane, I'll start with this, and then please feel free to jump in. POLST is an actionable medical order, and so that would mean changing a medical order. So that's usually how I respond to that question. I think it would probably, if someone wanted to do that or indicated that they did, that would certainly trigger a family meeting, a palliative care consult, an ethics committee meeting, all of the above. So, Jane, do you have anything to add to that?
And I also think it depends on your state. So you want to check your state laws regarding that. So, and of course, you need to determine, you know, has that role, I'm assuming that they're currently serving in that role, and then the individual no longer has decision-making capacity. So whether, or depending on the state, in Iowa, yes, you defer to the legal medical power of attorney or durable power of attorney for health care if the individual doesn't have decision-making capacity. My understanding is that is not the case in every state, so you want to check that. But in all situations, I think it's beneficial to go back to those conversations about what the individual specifically stated they wanted, assuming they were able to be a part of these conversations when POLST was implemented, and making their voice ever present when all of these discussions and potential changes are made.
Great.
Thank you all.
Great. Well, thank you. Yeah, and thank you for presenting today. I think we've actually reached the top of the hour, and I'd like to ask our presenters, Kandyce and Jane, if you have any final remarks.
This is Jane. I just want to say thank you so much for listening in, and we hope you will read the toolkit, and please feel free to contact the POLST organization, and they'll contact us if you have further questions or if we can be of further assistance.
Yes, and I as well would like to thank everyone for their patience and willingness to carve out some time to join us today. And I guess the word I would like to leave you all with is the value of collaboration, not only with POLST, but certainly with POLST given what we've spent the last hour discussing, but healthcare assessments, choices, treatments in general. Many perspectives really enhance the well-being of all of us. So thank you very much.
All right. Thank you both, and I will go ahead and end the webinar for today. And please have a great afternoon, everyone. Take care.